Good afternoon. My name is Mark Nash. Welcome to this talk that examines exercise and also lifestyle management in the lives of people who have spinal cord injuries, with a specific emphasis on cardiometabolic disease and all-cause cardioendocrine disease that is common after spinal cord injury. Cardioendocrine disease is a coalescing of multiple risk factors. There are 5 of them. Any 3 of them together confers a diagnosis that is cardiometabolic disease. And at the moment, this disease is an international pandemic that resembles worldwide pandemics of communicable diseases, and it causes much more death than COVID-19. These are prevalence rates for the occurrence in various populations. United States, roughly double the rest of the world, double the risk of diabetes, double the risk of heart disease. And if we look at Spain in particular, it's not much better there. Men are worse. Women are a little bit better, probably because your nutrition is better than ours and more aligned with the Mediterranean type of nutrition. The hazards of cardiometabolic disease is a 2-fold risk of all-cause cardiovascular disease. That means stroke, sudden death, and myocardial infarction. A 5-fold risk of type 2 diabetes, 3-fold risk of colon cancer, more breast cancer, 3.4% odds ratio for chronic kidney disease, and other things such as sleep-disordered breathing and erectile dysfunction. Much of what we see in this is wholly underdiagnosed, so the numbers that you see here are probably a bit optimistic. In people with spinal cord injury, at least in the United States, we see roughly 34% of the population having a guideline diagnosis of cardiometabolic disease. And of the 5 risk factors, obesity, low levels of the cardioprotective high-density lipoprotein cholesterol, insulin resistance, elevated fasting triglycerides, and hypertension. The most common that we see are obesity, at here showing 70%, but we've actually seen as high as 90%. 2/3 of the population having a dyslipidemia and HDL, and almost double the general population in the risk of either insulin resistance or frank diabetes. Okay? These are the defining levels of all of these risk factors for obtaining the diagnosis. Now, in addition to the cardiometabolic syndrome, there are other risk factors that are incorporated into all-cause cardioendocrine disease. Obviously, age, family history, gender go into it. In people with spinal cord injury also, major risk factors of physical deconditioning, of nutritional deficiency, which has been well documented in the population, and in a pro-inflammatory state. Once people have a spinal cord injury, the amount of inflammation going on of multiple systems is extraordinary. For the 5 risk factors of cardiometabolic disease, those that confer the diagnosis, there are 2 major ones. That's abdominal obesity and insulin resistance or type 2 diabetes. These are the major risk factors, and the minor ones, but still counted in, are hypertension, elevated fasting triglycerides, and low levels of HDL. And I always point out, many people study abdominal obesity and interventions on it. There is a low-hanging fruit in this, and the low-hanging fruit is actually insulin resistance. Okay, one with several weeks of exercise, one can correct this without changing anything else. And if we take the normal 3 hazards that we see, which are obesity, insulin resistance, and low HDL, if you get rid of one of those diagnoses, you get rid of the diagnosis of cardiometabolic disease. So there is a practice guideline that I chaired out of Washington through the Consortium of Spinal Cord Medicine. This is 23 spinal cord organizations, okay, that look at the guidelines that are generated by the Paralyzed Veterans of America. And you can go online and find all of them for shoulder, for bladder, for respiratory, and now for cardiometabolic disease. So I encourage you to look at this. I also wrote, which is on the same website, the spinal cord injury guidelines for identification and management in consumers. So there's now a consumer guide in lay language, okay, which explains what cardiometabolic disease is, what its component risks are, and how do you manage it. Now, what's the problem? Okay. There are a number of problems that contribute to this. Sedentary lifestyle, either adopted or imposed by spinal cord injury, is the reason for the low levels of exercise in this population. And in fact, since the 1980s, we've known that there's no population of individuals who has lower levels of fitness than someone who has a spinal cord injury. Otherwise, nutrition is poor. It's excessive in the total calories needed relative to daily activities. And the nutrition is both high in saturated fats and in general fats. Okay, there's also muscle atrophy, which contributes to the cardiometabolic disease, and I'll mention that at the end of the talk. All of these are modifiable risk factors. Okay, exercise, sedentary lifestyle can be modifiable to incorporating exercise. Okay, nutrition can be changed, and we'll show you what that looks like when we do it, and we'll suggest some ways in which muscle atrophy may be playing a future role in modifying these risks. Otherwise, there are other risks, some of them modifiable, some not at all modifiable, and some fall within the range of possible. Okay, obviously, age, sex, genetics are not modifiable. Stress is, habit strength is. Loneliness, depression, environment, access to healthcare in the United States is a risk. We'll talk about caregivers in the next slide. Okay, and of course, financial. So these may be modifiable, but not necessarily. But you can get rid of the diagnosis in most cases by removing one risk factor alone. And the most probable one for that is going to be insulin resistance or type 2 diabetes. Now, I don't want you to forget about the caregivers. Okay. In the United States, we have aging patients. We have aging caregivers. Okay, and we have to consider now with the aging caregivers, their caregiver disability. There is a statistic in the United States that by age 60, the people who care for those with spinal cord injury actually spend more time in the emergency room than the people they care for. So family members, parents, brothers and sisters, children sometimes, okay, here become adjuvant care providers. They are the new providers where we used to have nursing 24/7, 365 back in the 1980s. So there are caregivers now who are competing for good nutrition, for medications, and for rehabilitation services. And this is a part of what we are studying now is what is the relationship between the caregiver and the care receiver such that they can both take good care of themselves, okay, and last throughout the course of their lifespans. Both of them are aging. Now, it's somewhere about 2009, my colleague Trevor Hudson and I sat down and we wrote based upon what was then the guideline, the ATP3 guidelines of the National Institutes of Health, what one should look at for customized management of the disease. So the first thing we recommended was to eliminate drugs, pharmaceuticals, over-the-counter medicines that worsen the lipid or the glycemic profile. And the one that comes up most is tobacco. Okay, we need to stop our patients from smoking, from vaping, or from using other forms of tobacco. And if one does that, one does better. There's actually very little in the pharmacopoeia of people with spinal cord injury, mostly beta blockers, that worsen the lipid profile. So this isn't really the problem in most patients. We undertake nutritional modification. And as you'll see it's going to be Mediterranean for reasons I'll explain. We need to incorporate physical activity. We need to consider pharmacotherapy, but there actually isn't very much that's appropriate for individuals with spinal cord injury who are overweight and obese. The medications pose far greater risk than they do benefit. And the very last consideration is bariatric surgery. And if you read the guideline, we talk extensively about the risks of bariatric surgery in the population, both preoperative and postoperative, that make us want to have this be the very last resort in dealing with all-cause cardioendocrine disease. And as current as these were in 2009, they're really about the same in 2023. For these reasons, we like to think of the changes that are necessary as a lifestyle modification as opposed to either nutrition as a monotherapy or exercise as a monotherapy. Okay? Conventional wisdom says you can't out-exercise a bad diet. Okay? You cannot exercise so much, okay, that your poor diet becomes negligible. Conversely, nutrition doesn't do everything that exercise does. Okay, but we also have to recognize that in lifestyle modifications are challenging. And as our wise fellow Mark Twain told us years ago, lifestyle modification lasts about 2 weeks and is soluble in alcohol. So lifestyle is tough to do. Therefore, we need to have behavioral modification at the same time as we're making nutritional and exercise modification. Now, what do we know about effects of spinal cord injury on nutritional habits? Okay. The first is the nutrition is about 25% excessive in calories and it is high in saturated fat. We know that nutrition is worsened by lower metabolism, which are associated with injuries above T1, that is, those patients who have a functional sympathectomy. We know that overfeeding sometimes begins before the injury. People come in overweight and obese, and during rehabilitation, such that overweight and overfeeding becomes a habit. And this explains why the greatest weight gain after spinal cord injury occurs 2 to 7 months after the injury or after discharge from rehabilitation. Now, if you want an illustration of this, this is a woman who we studied back in 2004. She has a C5 Asia A neurologically complete spinal cord injury. And in fact, her spinal cord is transected, which is pretty rare. We did some metabolic studies on her, and we found that she burns about 875 kilocalories a day. So she already has an absolutely meager caloric expenditure during daily activities. And I wouldn't know how much to lower this in terms of kilocalorie intake without causing her more harm. And this gives us the idea, that we need combination strategies of exercise and nutrition if we're to achieve weight and cardiometabolic disease management. Ryan Selinsky and I have written on this and have a recent publication on how quickly this takes place within acute spinal cord injury. And my postdoctoral fellow, Gary Farkas, has actually computed out and found a prediction equation that modifies and tells us how many kilocalories a day somebody with a spinal cord injury basically burns. And that becomes the anchor for which we want to do some caloric restriction if it is possible. And this was recently published in the British Journal of Nutrition. So, fitness. Persons with spinal cord injury occupy the lowest segment of the human fitness continuum. There's nobody you could meet who has a lower level of fitness than somebody with spinal cord injury. And we have published in our work and also the work of a Norwegian scientist, the actual caloric expenditures that take place during exercise. Physical deconditioning commonly follows initial injury. Sometimes it's actually before injury. People come in deconditioned and they never recover to their pre-injury level. Population is aging, which worsens the already poor fitness prognosis, and the deconditioning is more than health. It is financial, it impacts the caregiver, it impacts society that has to pay for this, and all of these can be modified through positive health behavior. But we need to start early. Okay, so it's difficult for us to find a patient who's 20 years post-injury, who is morbidly obese, and then put them on a lifestyle management program that's going to do them a great deal of good. And for this reason, we work while patients are still in rehab in order to modify behaviors of both exercise and nutrition. Now, exercise is medicine, and we write an exercise prescription for our patients that is based upon something that is safe, that looks at all of the attributes of fitness. And it's not just cardiorespiratory endurance. It's strength, it's anaerobic power, and it's flexibility. We want to achieve balance in the musculoskeletal, okay, while sparing the shoulder, okay, and upper extremity decline. So here's Giuliani, who is from Brazil. She swears in Portuguese. I didn't put up what she said. But she's very, very tight here, and she's very, very loose in the supraspinatus, and she has a torn rotator cuff for that reason. So we need to find a balance and not just focus on the front of the chest and the upper arm. We need to consider the back. All of this has to be done while working to improve her function. And function means different things to different professionals. Okay? We want to enhance task performance. We want to make her ADLs easier. But as a physiologist, I also want to work on her homeostasis so that things like blood pressure control become easier for her and less an impingement on her lifestyle and the quality of life. We obviously want to address the risk factors we've talked about already, and we'd like to make it fun, and that will ensure compliance. So, again, in Portuguese, this is so much fun, but actually she does like it. There are fitness norms and guidelines for aerobic and strength conditioning after spinal cord injury. This is a short list of them, but all of these are authoritative guidelines, and surprisingly, they're all about the same. Okay? And all of them are described in our guidelines, both in the PVA Consortium and those that we use at the Miami Project. So there is aerobic or cardiorespiratory activity, and there's strength training activity. And I won't spend time going through them. We have recent publications on exercise to mitigate cardiometabolic disorders. And my colleague Kathleen Martin-Guinness has written a marvelous SR, a systematic review on evidence-based exercise guidelines for spinal cord injury. And we're all pretty much on the same page on this. You need cardiorespiratory exercise. You need strength training. How do we do it? Well, back in 1998, one of my doctoral students was doing this in insulin-dependent children, type 1 diabetic children. And so I stole her idea, lock, stock, and barrel, and made a spinal cord injury program out of it because the needs and the benefits we saw in her doing this were exactly what we needed and were looking for in spinal cord injury. So, and all of this, by the way, will be published soon, or actually the trial on treatment that describes all of this in exquisite detail has already been published. And we're waiting now for the publishing of the findings of the study, which I'll cover at the end of this talk. So this is Wilson. He has a mid-thoracic paraplegia. He's doing 6 resistance maneuvers. Okay, for each of them, he does 10 repetitions on 6-second lifts, 3 seconds concentric, 3 seconds eccentric, and then moves on to the next one, and then does 2 minutes of arm spinning as fast as he can. That's not to improve cardiorespiratory benefit. That's to clear lactate. And then he goes back and does the 3rd and the 4th. Then he spins for 2 minutes, and then he comes back and does the 5th exercise and the 6th. That is 1 cycle of this circuit. He does that 3 times. It takes about 43 minutes, and he has done everything he needs for his body in order to expend energy, make him functional, actually reduce his shoulder pain, as I'll show you in a minute, and also to oppose the risk of cardiometabolic disease. So what do we see with this? Okay. If a patient does this circuit that we do, okay, after 3 months, they will increase their cardiorespiratory fitness by almost 30%. And here's the interesting point. If you did cardiorespiratory exercise alone, you couldn't achieve that. So you actually get more cardiorespiratory benefit by lifting weights than you do with arm cycling alone. Okay? Time to fatigue, about the same. And this is important. Okay? We're about the only people who have reported an improvement in anaerobic power, the power one needs to push up a wheelchair ramp or across thick carpet or across stone. Okay? Now, in Miami, Miami is flat. It's basically, there are no mountains here, but I looked up Spain, and España no es plana. Okay, you have lots of these mountains and hills and things here. So I imagine that anaerobic power would be more important for your patients than for my patients unless they visited their relatives in Spain. Effects on strength. Strength acquisition in spinal cord injury is easy, okay, because the patients are so weak to begin with. Okay? And we actually don't need elbow flexion because there's really no flexor essentially deficit in strength, but the guys like to look good. So if they want to build up their arms and make them bulge a little bit more, if that's their motivation for doing that, that's perfectly okay with me. So we don't push them hard on elbow flexion, but we let them do their own thing. Now, the first study we published, we had some criticism because we did this in young, healthy people with spinal cord injury. So we did a follow-up trial in individuals who I called middle-aged. I'll define that in a minute. And also who had pain in their shoulders when they began the program. So we selected people who had pain, okay? And we get the same benefit. Okay? We get the same strength changes. Middle-aged, by the way, was defined as 1 year older than my wife. And we found that people who began the program with pain in their shoulders actually reduced their pain on a wheelchair user's shoulder pain index, which is validated for spinal cord injury. So even if you have older patients, and by the way, the upper age of this was 58, okay, they can still do this safely and benefit from it. The lipid profiles of the older people, we lowered their total cholesterol by 16%. We raised their poor or borderline level HDLs by 10%. We reduced their bad cholesterol by 26%. And the overall reduction in risk of the population was 23%. 1/4 of the risk was mitigated by this program. For individuals with tetraplegia, we had to do a separate program. So we modified the program. We gave them, we used wrist wraps with Velcro. We used D-rings to tie them onto equipment. And we used a lateral raise instead of a military press for the deltoids. And we played a trick on the body. And we published this in 2014. Johann Kressler was my postdoctoral fellow. We gave them 24 grams of whey protein in a shake before exercise, and immediately after exercise, another 24 grams. We threw a banana in there because it makes it taste good. Okay, and all we used was milk or water with this. And after 6 months, the people who took immediate post-exercise protein, IPS, immediate, had significantly greater gains in cardiorespiratory capacity than those here who delayed the input of the same whey protein. So there's a golden hour after exercise in which we can replete muscle glycogen. Okay? And this is an easy way to do it. Tastes good. Nobody objected to it. So it's a trick that we play on the muscles to make them stronger and more endurant. We've published this in elastic bands, TheraBand. Okay? I gave this to some graduate students in 2002. I said, design everything from this universal type equipment to be done on elastic bands. And they did. And it cost $50 or $60 to do this. And when we tested it, we found that there was no difference between the big metal weightlifting gym and people who are hanging TheraBands off doors in their home. Okay? And this is described in great detail in our 2002 archives publication. Now, for caregivers, much of what we've done is modeled after the National Diabetes Prevention Program, what we call DPP. Okay? And this program is the best and most effective program for weight management and diabetes prevention that we know of. The DPP used 10,000 steps and Mediterranean nutrition. That was it. Okay? And actually, the total steps now are less than 10,000. It's probably in the 7,000 to 8,000. So, if people did this, they experienced a 7% reduction in body mass, which reduced their risk for type 2 diabetes by 58%, and this benefit was more effective than giving them metformin as a pharmacotherapy. And what we know now, there are 3,000 programs like this across the United States. Okay? The program benefits are durable, they're long-lasting, they are cross-cutting for race, for gender, and for age, and they are cost-effective, and you don't need any special equipment or costs. And this is what we begin to use for the caregivers of people with spinal cord injury so that they remain healthy throughout their lifespan as well as the people they care for. So, how hard is it to do this? Okay. How high is the mountain that needs to be scaled? Do you have to climb Mount Everest? And the answer is no. I tell my patients, you just have to get over the hill. And if you do this, 7% lowering of body mass reduces risk for type 2 diabetes by 58%. And if you get rid of this risk, you have now reduced the risk of cardioendocrine disease, cardiometabolic disease. All of this in detail for both professionals and for patients, okay, is on our Miami Project website. We have a healthy lifestyle page, okay, and there is a book on here which describes for both professionals like you and your patients how to go about doing this, including some nutritional modification for them to get them started. Now, we've tested this combination type therapy. And the first of the papers we published was a couple years ago, was a case series in which we did lifestyle intervention to address cardiometabolic risks. And the first 3 subjects did the exercise I've described for you. They did a Mediterranean nutrition. And if your question is, why Mediterranean? First of all, it works. Second, it's not one nutritional plan. You can modify Mediterranean in hundreds of ways and still have it work. And it can be used by people who eat meat. Okay, so you don't have to be a vegan. Okay, you don't have to restrict salt to draconian levels. Okay, just follow a Mediterranean nutrition with the caloric targets that we give. And then we designed a behavioral program, which is on the Miami Project website, that teaches individuals about food and exercise, what their goals are, and how to live a daily life. Okay? And also how to problem solve. If you go to a restaurant, what are you going to eat? If you go to your friends, what are you going to eat? So all of this is modifiable. And if we do this, we publish this already, body mass comes down more than 7%. Fasting glucose comes down close to 10%. And by the way, stays down after 12 months of almost no supervision. Insulin resistance, the low-hanging fruit, this is the homeostasis insulin resistance model, comes down from diabetic to non-diabetic in 6 months and stays there 6 months later with minimal supervision. This is an astounding statistic. HDL goes up 10% or more, what we'd expect in an exercise training program, and we get lowered triglycerides, and this remains fairly stable 6 months after. Now, beyond this, we now have a fully controlled crossover trial, okay, properly powered, which is being published, that repeated this in a larger population, but then included questions like health-related quality of life. Okay? And what I can tell you is these statistics hold. Okay? And in fact, they're a little bit better, and we have now tied the reduction in body mass with an improvement in health-related quality of life as perceived by the study participants and by their caregivers. Okay? And we expect this to be out pretty soon. It's now in press in the International Journal of Environmental Research and Public Health. So we have a program that has now been published in exquisite detail on how to do this. We have data here and here that it works, and that patients who do it recognize that their lives get better because of it. What else would you want to know? What else should you? So, conclusiones, cardiometabolic disease and obesity are serious secondary health threats after spinal cord injury. There's no longer a debate about this. And if we don't act, the consequences to adversely impact activity, life satisfaction, productivity, health, and independence is substantial. These are the words I think of when I think of rehab. I want my patients active, satisfied, productive. I want them healthy, and I certainly want them independent. So also do I want their caregivers to have the same benefits of this type of activities. We know what works for some, lifestyle intervention. Maybe it's not for everybody, but for a high percentage of people it is. Exercise plays a critical role, okay? But it's not exclusive. We need to match this up with nutrition and modified behavior. Otherwise, we're going to come up short. And just the same, nutrition and behavioral intervention shouldn't be overlooked. They may alone not solve the problem. They need exercise. Okay? And for those who cannot exercise, I'm just putting this on your radar map, we have been performing experiments, preclinical models in spinal cord injured animals that have looked at modifying gene expression of muscle development. And we have found some clever new ways to do this, both with a nutraceutical called ursolic acid and a myostatin inhibitor, an antibody which grows muscle. Okay? And you can go on to clinicaltrials.gov, put in myostatin inhibition, and you will see human trials that are ongoing in other diagnoses that are doing this. We have human work going on now in ursolic acid, and our early data show that people with spinal cord injury benefit from this in the same way that our experimental animals did. This was published in PLOS One in 2018. So if we can build muscle, we can have more of an engine that burns calories, that reduces fat, okay, and makes people look and feel better. And that is our ultimate goal. Okay? We don't have to do this. We don't need Mount Everest. We just need to get over the hill. And once patients discover this, okay, they actually find they like this. There are always those who say Mediterranean diet nutrition is expensive. And I tell them nothing is more expensive than McDonald's. Nothing is more expensive than fast food. Okay? And we have tools that we use, educational tools, that teach people how to shop in the supermarket for nutritional modification using Mediterranean nutrition. So, with my gratitude, it takes a lot of people to do this. This is Francisco Diaz, who is both my research subject and runs our cardiometabolic exercise laboratory. Okay? He was spinal cord injured 35 years ago. He was diabetic until he did exactly what I told him to do, and he no longer takes metformin. And with him is me. So we're grateful for all of my colleagues, their centers, the United States Model Systems through NIDLR, the Paralyzed Veterans and the Consortium for Spinal Cord Medicine. And this is my third integrated work with Hollister. I have enjoyed my contacts with them. I was in Belgium, in Reims, several years ago to meet with them and to present a plenary. We saw them at the Miami Project and enjoyed our interactions, and I appreciate the opportunity to present here as well. So thank you very much.